Here we are with Dr. Nina Mingioni, and we've agreed we're going to be calling you Nina today.
Yes.
And even though you're much more important than at least me at this table, I don't want to put down Dr. Paul Williams.
Kind of a big deal.
Yeah, Paul's very important. Stuart is too.
No.
But today we're going to be talking about some more highlights from the ACP meeting in New Orleans from 2018. But before we get to those, we just wanted the audience to get to know you. So I wanted to say, can you give them a one-liner, kind of give them a flavor of your personality, who you are?
All right. So I'm a 41-year-old proud general internist and a medical educator. I'm a mother of two. I'm a pragmatic realist and an adventurous eater.
Okay. An adventurous eater.
Or at least you used to be.
At least I used to be, but we'll get into that later.
My one-liner includes the fact that I have very weird eating habits, which Stuart can attest to, having worked with me.
Yes. His breakfast is like kale and beans and a little bit of milk, and I don't know what that is.
I think I might be validated based on the teaser that Nina gave us.
Probably.
Absolutely.
Yeah. Okay. All right.
Gross.
Stuart or Paul, did you have any follow-up questions?
I'll ask my usual. Any book recommendations? Does not have to be medically based if you don't want to.
So my reading time has gone to nothing, and mainly because I tend to binge on books and stop sleeping until I finish. So
what are you reading?
So actually the most recent adult book I read was by Lindsay Addario. She is a wartime photojournalist, and this was her memoir that came out a couple years ago, and it was absolutely fantastic. I dabble in photography a little bit, so this actually spoke to me quite a bit, and she's amazing. Very brave, and more so than I could ever be. And then the most recent book I read, period, just finished last week, which I highly recommend to people who've got kids, is Wonder by Palacio.
Right.
By R.J. Palacio. And it was fantastic. So I read it with my 7-year-old, and it was great.
That was a great book. There's actually a sequel to that as well.
It's actually not a sequel. It's like little side stories.
Yeah.
Because we got it, and I was disappointed it's not a sequel.
Yeah, it's from someone else's perspective, I think, if I remember correctly.
Yeah, from the bully's perspective.
That's right.
So to be clear, our audience shouldn't waste their time with the so-called sequel that Stuart was recommending.
Correct. Definitely read the original.
Okay.
My kids for good recommendations.
Stuart.
Yeah. What's the best advice you've either given or received as a teacher or learner? A lot of ors there.
So as a learner, and I'm not sure who I heard this from first, but I've heard from some pretty respected faculty members to remember to spend some time on me, which I've pretty much blown off until fairly recently. And I have to say now I give my learners the same advice, to establish exercise habits early and to stick with them, and do something for just yourself and keep a hobby, if that's at all possible, while having a busy internal medicine career.
That has been a big theme, I think, for everybody at this meeting, and certainly for the ACP themselves, like all the recent papers they're putting out on the topic.
Yeah, focus on burnout.
Yes.
Well, let's move into the fun learning that we did at this conference. Why don't you tell us about you went to the talk titled "Athlete as a Patient," and what did you learn there that you think would be useful for the audience to know?
So this was a very interesting session, actually. It was led by Dr. Gary Dorsheimer, who is a physician to the Phillies and the Eagles, and I'm from Philly, so this means a lot to me. Of course, I will never see a competitive athlete as a patient. But it was, a little bit of stardom there, so it's good. So a couple of things he did talk about that I thought was interesting is, since I am a primary care doctor, I do see younger folks, mainly high school, not high school, but college athletes still come in for pre-participation physicals. Mm-hmm. And he reviewed the guidelines that came out in 2007 by AHA that talked about the various aspects of history and physical that should be done on those folks, and mainly history checking for exertional symptoms, syncope, things like you would imagine, history of murmurs and family history of any issues in sudden cardiac death, and then specifically doing physical exam, listening for murmurs, and doing femoral pulses, looking at Marfan's physiology, blood pressure, things like that. I should say Marfan's morphology, not physiology, sorry. And then the outcome of that sort of blurb is that routine EKGs are not recommended actually for high school or for college athletes. And that's because there is such a high prevalence of various adaptations of an athlete's heart that gives you EKG abnormalities that somebody who's not used to looking at athletes' EKGs will not be able to pick up. So EKGs were not useful in that population whatsoever and should not be performed.
Right. Yeah. I'm used to looking at like the EKG of a 70 or 80-year-old with like multimorbidity and a sick heart. So yeah, when I see a normal heart, I'm like, what is this? This person's dying. Like, what is happening here? So
what about for the older adults?
So there's not as many, definitely no consensus recommendations for the older adults. There was a paper that came out in 2015 in British Journal of Sports Medicine that looked at recreational athletes. So this was immediately relevant to me and my ears perked up. I am not much of an athlete, but I do try to exercise. I should say that for the record.
Can we not call it older adults, please? I mean, that's just adults. Can we just say adults? Like,
Yeah,
I don't think
say
older
adults.
needs to be a qualifier for a 35-year-old. That's just...
I have to say, as I get older, what I consider middle-aged has been shifting up. And I hear that from they talk about that, the very senior faculty talk about how the geriatric population age line keeps moving up.
Yeah, I
but
agree.
I find that for middle-aged, I consider myself very young still.
Yeah,
it's all
like
good.
having your midlife crisis at 70, I feel like is appropriate.
I agree. I have no time for midlife crisis. It's not on the agenda. So this specific paper looked at 785 individuals who were 35 to 65 years old. Mean age was 46.8, but they were 73% men, and they engaged in high intensity sports. So they did full history, full physical, and about 14.3% required some sort of additional testing based on what the researchers determined to be appropriate. So either they were high risk for coronary disease or had very high cholesterol, something like that. So they found that about 5% had abnormal EKGs of some sort. And out of all the people that got tested for various things, they actually found that there were only 3 people of that cohort of 785 that needed to be excluded from physical activity based on what they found. And all 3 were identified based on their abnormal baseline EKGs, actually. So whoever needed echoes or stress tests or whatever else, all of those were actually normal. So it was actually the resting EKG that identified all the people with issues. So these are not guidelines. This is a single paper that came out. This is, not the highest studied population, I suppose. But Dr. Dorsheimer said maybe consider an EKG in your recreational athletes. Of course, again, this is not guidelines, but this is something to keep in mind.
Okay. And there was you told us there was a part on the female athlete triad, which we're not calling it that anymore. So what's the update there?
Correct. So I actually thought that was very interesting because for the last several years, I've been reading about female athlete triad, which is generally was considered to be women who are calorically restricting in some way and are exercising, and they can get amenorrhea, oligomenorrhea, and they generally have some alteration in bone density. So though not always, sometimes they'll have like low normal bone density or, frank osteopenia, and sometimes even osteoporosis. So there was a consensus statement that came out from the International Olympic Committee that actually recognized that this is not a syndrome that's limited to women only, and that men are also susceptible to this. And they renamed it relative energy deficiency in sports, which I like because it's a self-descriptive syndrome.
Right.
So I think you can figure out, what that means based on that. But what was interesting is that there are a whole host of physiologic effects of this that clearly go beyond bone health and gynecologic health, which I thought was really important to recognize.
We had talked several episodes ago with Roz Kaplan, Dr. Kaplan, also at Jefferson, about this, and she was pointing out to us that the young male athlete is at a higher risk for eating disorders as well, which is something I had not really ever heard or thought about before.
Yeah, I think it's very important to recognize.
Mm-hmm. Stuart, what are we going on to next?
I believe the next thing that we have is, I got to look at my script, right?
Okay, I'm
the,
sorry.
The drug interactions. Sorry.
Yeah. Okay. So on to drug interactions, and what there was a talk on the top drug interactions of 2018.
Correct. A lot of them were not necessarily from 2018, but there's always a list of top favorites, right? That we, I like to be reminded once a year. I think the more you get beaten over the head about these things. probably the best it is. So warfarin is always on top of the list. And I think everybody at this point knows about TMP sulfa. Increasing the INR. So apparently the mean increase in INR while on trimethoprim sulfamethoxazole was 1.76, which is quite a bit.
Cow.
That's crazy.
Yeah, right? Isn't it impressive? And what I did not realize is how much prednisone raises INRs. And in the one study they showed, it was 1.24 increase in INR.
Jeez.
Yikes.
I know, so that's something
significant.
to be aware of. And the third, I thought, really important nugget they mentioned is that acetaminophen can raise INR as well. They didn't have a clean number to put with that, but specifically chronic acetaminophen use greater than 1.5 gram a day can significantly increase INR. So those people,
Not that much.
1.5 grams a day is not that much. So I prescribe that in my elderly patients quite routinely for aches and
Yeah, of
pains.
course.
So that's something to keep in mind.
Any other drug interactions that you wanted to highlight?
Anything else anxiety provoking you want to throw out there? I need to make some phone calls.
What else are we messing up with drugs these days?
So actually, there was a good one. So as a primary care doc, I love me some SSRIs and I prescribe them a lot. I also love treating migraines and I treat those a lot with triptans. And invariably, I get either a phone call from the pharmacist or those alerts that you get that pop up on EMR that I should not be saying on air, frequently ignore because they're always the same. Or I get letters from the insurance companies about the potential for serotonin syndrome when you combine SSRIs with triptans. And the evidence is looking like it really was an overblown concern at this point. So from the original literature that was examined by the FDA back, I guess it was 2007 or something like that. They, I think, overdiagnosed serotonin syndrome. So more literature came out this year that the combination of the two is extremely unlikely to produce serotonin syndrome, which is really good for our patients and me. Usually, if there is a serotonin syndrome, it's because there's a third agent on board that also affects certain allergic pathways, like tramadol or something to that extent, and that would precipitate serotonin syndrome. So prescribe away. Triptans and SSRIs.
Avoid amitriptyl.
We've had multiple shows where we talked about drug interactions, or we've had pharmacist friends on, and I think when we were talking about specifically the risk of torsades or QT prolongation, our pharmacist friend Neela was saying actually it's multiple hits, so you always want to look out for that. So when you're on the med list, if you're adding the third or fourth agent that's going to have a serotonin effect, then that's where you're going to get into trouble. And so I love talking about this stuff because I find that I just see so much irresponsible prescribing. It drives me crazy.
Yeah.
I agree.
My biggest concern is when someone's seeing a psychiatrist, they come back and they're on multiple serotonergic meds. And then on top of that, they're probably on Cymbalta for some other reason too.
Yeah. Yeah. I see that. I'm like, you're on an SSRI and an SNRI and you're taking trazodone for sleep and tramadol for pain. This makes me really uncomfortable. But anyway,
I agree. It's hard in the trenches. Serotonin is the thing.
Yes.
And
this is my therapy, on-air therapy right here.
their intake vitals heart rate of 120 and they're sweating.
I know. That's a whole separate podcast, right?
Yes.
So.
Let's move on to food as medicine so you could tell everybody why my weird eating habits are actually beneficial to me.
So this was a really fascinating talk I attended by Michelle McMacken from NYU. So she started off by saying that about 45% of all cardiometabolic mortality actually can be attributed to poor eating habits, which is a really scary thought. And then she also, she gave a nice overview of a lot of different evidence about what we should be eating in various diets, et cetera. And it basically all came down to a summary, like a single statement by a food writer, Michael Pollan, that basically goes something like this: eat food, not too much, and mostly plants. So, she said that basically when you look at the evidence for foods there, she called them green box foods, which are healthful foods, whole grains, legumes, fruits, veggies, not seeds. There's clearly unhealthful foods, which is processed meat, red meat, added sugar, refined grains, ultra processed foods, etc. And then there was a big category of debatable, which gave me a big pause, which was poultry, eggs, dairy, and fish, which I traditionally consider healthy food.
Sure.
So I was absolutely not happy to see that in the yellow box. So the the one slide that she showed, and that sort of will segue into the microbiome talk that I attended, is that when they looked at, so again, with the microbiome, there's a lot of associations, not a lot of causality that's been proven yet, so they're still working on that. But they looked at phosphatidylcholine that you get from eating a meat-based diet, and it gets converted to choline in the gut. And then when gut flora gets a hold of it, and Dr. Young from the microbiome talk will say, gut microbiota, not flora, because they're not plants. They convert it to TMA, which is trimethylamine, which then by liver gets converted to trimethylamine oxide, and that is atherogenic, apparently. So intake of any meat is directly atherogenic, as it turns out. So I came into the conference here in New Orleans on Wednesday, and my first stop was dinner with some andouille gumbo. And I'm sad to say that I've not eaten any red meat since then. I had to have a little bit of fish along the way, but that's about it. And I've had like a lost appetite for meat, and probably will last till the end of this week. I'm not sure I will permanently give up my meat eating habits. But it certainly reinforced at least my personal recent efforts for eating a lot more legumes. I already eat a lot of fruits and veggies, but I will have to look at my dairy and egg habit.
Was the speaker's list of disclosures like, I am a vegetarian, I may be biased against all types of meat?
No, it wasn't. So
Okay.
she actually gave a well-balanced talk, I thought.
Okay.
So, but I think she made a pretty compelling point. Again, I think it's not realistic for most of us to eat that kind of diet. I think it's too much of a change, to be honest with you. Maybe eventually in better human, some future, we actually eat that way.
But avoiding I think everybody is like feeling somewhat, at least maybe I'm projecting, I probably am. But
Yeah,
if you're eating, Paul, correct me if I'm wrong. If you're eating eggs, chicken, fish, you probably feel better that if you're eating like bacon, ribs, things like that. You think you're doing better.
Do you mean spiritually or like physically better?
No, I just mean like you think most
Yes.
people assume
You're
that's
correct.
better, but this is in the yellow category of maybe harmful.
Correct. So
is that based on like observational data? Did she give any like resources or just
all she reviewed some literature. So all the studies, of course, are very small. A lot of it is just suggested data, not direct causation. So I think a lot more work needs to be done in the area. With that said, some of the data was compelling enough that I was like, again, I'm not willing to permanently give up my meat eating. My 7-year-old eats a hamburger at least once a week, and that's like a requirement for peace at home. So, I think stay tuned is the message here. What was interesting is that she did not specifically recommend like ketogenic diet for weight loss or anything of that sort. It really specifically was, plant-based diet is what looks to be the most beneficial at this point.
Was there any comment on non-GMO and on organic?
She did not touch upon
Probably wise.
GMOs and organics, which I think was wise. I agree.
Any specific tips in terms of patient counseling that came up?
Yes, I actually thought that was a really good point. And I do a lot of patient counseling, and I always need, I'm always looking for phrases that make it sort of more relevant to patients. So the one thing that she recommended that I thought was really good is not to counsel patients in terms of nutrients, but to talk about specific foods. So she would say, like, don't tell them to decrease animal protein. Just say like, hey, you should eat less meat and more, whole grains and more legumes and more beans to get your protein content. So I thought that was very, very helpful. The other thing I thought was very, very relevant is to make sure that they make very specific goals. So instead of thinking like, oh, I will drink less soda, to say something like, oh, I will give up a soda at lunch, and instead I will drink water. So very, very specific, attainable things that you can hold patients to.
I like and I'm probably going to mess his name up, but Dr. L. Yemen, it was a functional medicine doctor we had on way back. And he told us that he counsels his patients, like things that come out of a bag, box, or can that tend to be processed. Try to get 80% of your food from something other than a bag, box, or can.
That's a great
And that's
advice.
kind of forcing you to eat whole foods. But, technically they could make the other 20% like all bacon. So, maybe that's not specific enough. I think the last.
So it's actually my specific diet.
I think
You're doing okay, Paul. 8% of the time.
I think the last topic we had was marijuana use, which is a favorite topic of the show. Yeah. This was actually a marijuana podcast that turned into a med ed podcast.
You had something to discuss every single week.
Yeah.
Impressive.
Hence the bacon.
Yesterday was 420 as well, right? If we're being honest, yeah. Okay.
Excellent.
I'll probably have to cut all that out.
I would, please. I have a job and a family.
No longer have a job. All right.
So the reason why I went to Marijuana Talk is because it was recently legalized for medicinal use in Pennsylvania, where I work, and I know absolutely nothing about marijuana and its prescription. I definitely have patients who started asking. My place of employment, which is the awesome Thomas Jefferson University Hospital, now has the Lambert Center for Study of Medicinal Cannabis and Hemp. So I'm not sure, I think it's mostly research driven at this point, but they have been advertising after my patients ask about, how do they go and get hooked up to get some medicinal marijuana.
Of course.
So I thought it'd be interesting to learn something about it. I was pleased to see the guy who runs the center at Jefferson as actually the main speaker, and his name is Charles Pollack. And he gave an interesting overview of the use of cannabis in the United States and also some history, which was pretty impressive. So the couple of things I learned from that is that so the main psychoactive compound in cannabis is actually THC, which is delta-9 tetrahydrocannabinol. But the main medicinally related compound is actually cannabidiol, CBD. So they're two different things. And the two cannabis-related products that are available for use in the U.S. as the FDA-approved compounds are both THC analogs, synthetic THC analogs, which is the psychoactive compound, not the medicinal compound. And there are no CBD synthetic compounds. The other interesting concept is that all the medicinal effects traditionally associated with marijuana, nobody's really sure what are all of the compounds that contribute to this, because there's over 400 active compounds in marijuana leaf. And traditionally people smoke the whole, the flowers, the leaves or whatever, but it's using the whole plant. So there are a lot of terpenoids and flavonoids that contribute to the sort of the traditional or associated smell or taste of marijuana that probably have some effects as well, but nobody's looking at those. So they actually call it the entourage effect. So even though you may be looking at a single synthetic substance for its medicinal uses, you're losing that entourage effect that comes with using the whole plant.
The first time you said the entourage effect, I thought you were talking about the HBO series, and I was like, that seems...
I knew that's where your head went.
That's exactly what I thought when he mentioned it. I had to look it up to be honest.
I'm sorry, Paul. I couldn't resist. I couldn't resist. I know that was your favorite show, so
big pivot head.
Any follow-ups to that, guys? Any thoughts, Paul? Are you using this in your practice?
No, not. I'm certainly being asked about it, but it's not something I'm either trained to prescribe, and I'm still a little bit dubious, as we discussed previously.
Mm-hmm. So I think it's really tricky. And again, some of the interesting things I didn't realize, I was like, well, maybe there'll just be a doc who prescribes marijuana. I can just send them to that doc. But since there's no really synthetic compounds for stuff that we're looking for, and federally marijuana is still illegal. It's a Category 1 substance. So states made it legal. So you actually can still get arrested, I guess, for possession or, on federal charges. So it gets pretty tricky. But even dosing gets, really, really tricky. So let me actually pull up my...
We talked about that on one of our episodes.
My notes on this. I never thought about this stuff.
How many gummy bears are you supposed to prescribe?
Right, exactly. So there is it's smoked, it's vaporized, there's edibles, there's also tinctures and oils. Mm-hmm. And the oils is the ones where you can control THC to CBD ratio. Mm-hmm. And they really make it so that there's very little THC, the psychoactive stuff, and a lot more of CBD. But the oils is the one that people will use in kids with seizures and things of that sort. But for your patients, what do you prescribe? One puff with me? I mean, what do you prescribe? So it's, and the other problem is that there's high variations of active compounds, crop to crop, batch to batch. So there's no standardization. So I think, stay tuned. I think the evidence, I would love to say the evidence is forthcoming, but it probably won't be coming out of the United States because apparently it's nearly impossible to get the plants for research because it's a class 1, so Category 1 substance. And apparently all plants come from a single growing facility in Mississippi that's federally controlled. So a lot of the research actually is happening overseas where it's easier to get.
Yeah, I have a couple of patients anecdotally that either ordering CBD oil, mail order, or just making their own, which I don't ask too much about. And they say that they're doing great with it. But I think the possible exciting use for it is maybe to transition patients off of opioids. Like I think that's something that we've all been sort of thinking about as a possible use of this drug. But I just feel like I still don't know enough about it as much as we've talked about it.
Correct. So I think this gave me a little bit more insight into the challenges associated with, but definitely brought me no closer to prescribing it medicinally.
Right.
Not that I'm looking to get into that, please.
The fact that it's a class 1 or category 1 substance, when we had talked with Dr. Donald Abrams about this topic, he was saying that they can only study the adverse effects of marijuana. So all the evidence about like what it does to help people has to just be observational studies, like sort of like as a piggyback on to the adverse effects study that they were doing.
Correct. And yes, it's really difficult to study because there's so many different substances within the actual plant. So it's difficult to figure out which exact substance has which medicinal effect. So it's going to be pretty tricky.
And that's why the few times it's been mentioned on the show, the expert or the expert has recommended whole plant. And So whole plant. And the other thing was that people should know that if they're prescribing marijuana to their patients, when they smoke marijuana, it's like 2.5 minutes, it starts to reach a level in the bloodstream versus when they ingest it, it's 2.5 hours later. So, Dr. Abrams was saying he would prescribe it, like his little old lady patient would go to the bud tender and they would give her a brownie and she would eat it and start like tripping 2.5 hours later. He recommends they they would use whole plant and smoke so they know like they can feel the effects and they can sort of titrate better. Just some practical tips for marijuana from someone who has very little knowledge of it.
Well, but it's relevant because I think in Pennsylvania, my understanding is it's the only thing that's going to be allowed to be dispensed is going to be edibles. I don't think that there's going to be any product to be smoked. So it's that counseling will be important. We have to reframe this conversation. I cannot participate if there's going to be a bud tender. I'm not going to do it.
You don't mean this specific conversation. You mean like the national conversation about marijuana.
Prescribing it. Like I need to feel something like a professional. I can't say go to your bud
problem
tender.
is the nomenclature?
Yeah, exactly.
So just change the term bud tender to something else?
Yeah, absolutely. That's all it takes.
I'm sure Stuart can think of something.
I wish that he would not.
Of a more suitable pun to come up with that name.
I don't know.
Okay, well, Nina, this has been awesome. Thank you so much. And I know you worked very hard to go to all these sessions and put together all these pearls. I like to think it's for us, but I know it was really the ACP asked you to do that, and they are much more important than us. So, but do you have any favorite take-home points you want to leave the audience with, or anything you'd like to plug or ask of the audience?
No, I mean, I think ACP is an awesome conference. They're not paying me to say this. It's probably it is my favorite clinical conference that I always try to come to. So I'm going to 12 different sessions, which is a ton.
Oh my God.
I know I went to 10 in the last 2 days, so I'm pretty burnt out. I went to 7 a.m. this morning.
Oh, God bless you.
One more to go. So definitely try to attend. I think it's an incredible experience, and to also see a lot of other internists, general internists who are here to learn and to run into old colleagues and old friends, which also been really great. But otherwise, yes, eat plants. Do not eat andouille sausage. And but when you see me next week, I'll probably be eating a burger or something.
With your 7-year-old, right?
With my 7-year-old.
Well, listen, quality of life counts for something too. So
absolutely.
Exactly.
So that's it.